Hey, besties, welcome to another episode of the Nurse Aspect where we assess and evaluate. I'm your host, Nurse Becca, and today we have on the show Nurse.
Jasmine,
Hey, Jasmine.
hi, how are you?
I'm good. How are you? First of all, if you guys are just listening and you can't see the video on YouTube right now, Jasmine is looking very Easter Sunday,
All right.
very pretty in purple right
Thank you.
now, looking
Thank you.
gorgeous. Makeup is on point.
Thank you. Thank you. As well as
Oh,
you.
thank
You look
you.
lovely.
Thank you. How are you feeling?
I'm feeling good. I thank you for, inviting me on your show.
Of
This is
course.
just amazing and great vibes and, lovely lady. And so I'm happy to be here.
All right, well, we're gonna get right into it.
All right.
Okay, why'd you get into nursing?
All right. So my journey began because of my parents. My mother was a phlebotomist when I was young. My dad was in social work.
Oh,
And so I was fascinated with my mother drawing blood for
mm-hmm.
whatever reason. And that was my first taste of healthcare. And then I would attend many of these programs that would talk to young kids about nursing. So I started going to a lot of those programs. I think it was a hospital on the weekend who would offer these opportunities for kids, youth to visit their school, show you how you would care for a patient, which was the mannequin, show
Mm-hmm.
you videos about caring for patients. And so I was always interested in nursing from there.
Okay.
Yeah.
All right. So, what did you start out in your career?
So my career, I've been interested in nursing for forever. So it was my track. I went to school for nursing. I didn't change course at all. I started, when you say when did I started, where do I start in terms of
In
type
terms
of
of like working?
unit?
Yeah.
I started in a medical surgical unit, which
Okay.
was a hybrid of step down at the time.
Mm.
And so it was a mix of medicine step down with a mix of stroke step down
Oof.
and medicine acute patients in between, all
Mm.
things mostly. Not as much cardiac, but anything in between. So
Mm-hmm.
two step down units with a medicine surgical
Oof,
unit.
that neuro boy.
Yes.
I can't do them Q15 neuro
Although
checks
there
and
was a lot. There was a
uh
lot. Yes.
so it's like a baby ICU to me. I feel like whenever you have like a step down unit, that's exactly what it is to me.
I felt like med surge, that's one thing. Step downs were always, I felt like, where the storm is. And
Mm-hmm.
then when they're sent to the ICU, I felt like that's when the patient's sedated and then
Yeah,
calm. That's what
because
we
as
always
soon as
felt
they wake
like.
up in the ICU, now it's time to downgrade you.
Yes,
Like,
yes,
you gotta leave the floor.
yes.
And then how long did you stay there? Did you move around?
So I was in med surge for about 4 years, and
Mhm.
then I went to the epilepsy route.
Oh, wow, okay.
So it was more specialized. I had a huge psychiatry component to it,
Mhm.
but it was caring for both adults and some pediatric patients,
Oh,
like age
wow.
13 and up.
Okay.
So it was interesting, and I enjoyed it because I did feel like I had a lot of opportunity to really care for the patient and talk to the patient. So it was a very interesting time, and epilepsy is a little bit different from what people are used, what they expect seizures to look like. There was
How
so
so?
many types of seizures
Yes.
where we're used to someone having the grand mal seizure type with the
Mhm.
tensing up and the tonic clonic jerking,
Mhm.
but there are so many types of seizures, such as staring spells,
Right.
or someone could have challenges in school and they may think that the student and the kid is not paying attention, but
They're having like a
their
focal.
focus
Yeah.
is impaired because of the seizure.
Mhm.
And the so many intricacies and surgical interventions of what can be done to help with seizures, but there's so many presentations of seizures. So that was something that was interesting to me about working in epilepsy.
Is there anything you didn't like about working in epilepsy?
Well, it's nothing that I didn't like working in epilepsy, but in being as a nurse, that you're working in a field where not every patient is going to get well,
Mhm.
right? Some patients are going to, still be sick or get worse.
Yeah.
Seizures and epilepsy can affect someone's independence and
Mhm.
the way that they've, became a patient, who has seizures. Some people were attacked and beaten. They have
Mhm.
head trauma or they have a tumor. And their life is impaired, going out day to day, trying to function by themselves,
Mhm.
just to see potentially a patient going to their prom. That's
Mhm.
nice to see that they're able to have some level of independence, but some patients can't. and it
Yeah.
affects their life. So in that aspect of epilepsy, that can be a little sad for patients when they're not going to get better.
Hmm.
You hope that they will, but
Of course.
that's the aspect of it. But I enjoyed bringing some humor and joy to some of the patients. Sometimes you may be dealing with patients who are developmentally delayed or just young kids, and so trying to keep their spirits up, that was something that I enjoyed.
Mhm.
That was it. I really didn't have any bad, feelings or thoughts about working in epilepsy.
I honestly didn't even know that there was a different area. I always considered like this is all just neuro. I didn't know that this was like a subspecialty in a specialty itself. Had no idea that that was a thing.
Yes, I mean, there are, places depending on the level, like you have trauma levels, you have different levels for epilepsy centers, and they can go from, assessments of putting on, electrodes onto the person's, scalp and trying to assess if this is in fact a seizure or something else, because
Mm.
some people have presentations that mimic seizures, but they could have trauma for maybe potentially like sexual assault. And they're
Mm.
they're acting out in ways that mimic a seizure, but there's no electrical activity to state
Mm.
that they're having a seizure. Then there's people who need medication adjustment, so they'll come into centers to get their meds adjusted.
Okay.
And then there's people who need to potentially have surgery, so they can do surgical evaluations. So what they'll do is lower their seizure medication to try to create a seizure response.
Mhm.
And it could be things just as much as holding the medications, giving photic stimulation lights. It could even be giving them sips of alcohol to help
Oh,
to try
wow.
to get a seizure response,
Mhm.
capture that seizure, and then from wherever it's showing up on the side in the brain, they can then proceed with some surgical intervention, whether it's taking out
Oh.
a piece of that focal seizure point,
Mhm.
or even such as creating slits in the brain to kind of break up the communication of the seizure.
Mhm.
So it's a lot of fascinating things they can do. Doing some diagnostic tests to highlight the parts of the brain that illuminate when there's a seizure to kind of get an idea, like a nuclear medicine, to get an idea of where the seizure is coming from. Hmm.
Working in epilepsy, were you ever like in the OR as well as part of your role too, or no?
No, but I mean, the fascinating thing about orientation on a unit or a specialty unit, you may have the opportunity to attend or be a part of observing a surgery. So I was
Okay.
able to see one of the cranial surgeries that was taking place for an epilepsy patient, but we were not, it was not part of our role, like
Okay.
an L&D who might be in a PACU
Yes.
OR
Right.
setting. No.
Okay. All right. And
Yeah.
then where'd you go from there?
So from med surge to epilepsy, I then went to the educator route. So
Okay.
in the interim, while I was doing my, full time as a epilepsy nurse at the bedside, I also did per diem vaccine nurse
Oh.
in the city.
Mhm.
So
Mhm.
that was fun to go down to like the financial district and give out,
Injections.
vaccines,
Yeah.
and that was fun. And to go to
Okay.
their health fairs and things like that. So
Mhm.
that was my first entry into making some side cash.
I swear, most nurses have a little side
Mhm.
hustle, so I'm not mad at that.
Right, this was pre-COVID time back then,
Oh,
so,
okay.
people have their thoughts about vaccines, but
Mhm.
back then, it was on your terms, what availability you had to go and
Mhm.
to do that, so that was fun.
Mhm.
While I was on the epilepsy unit, I went back part-time to get my master's in nursing education. So
Mhm.
then as I was doing that, and I graduated, I was able to do, adjunct instructor
Okay.
at the school that I went to school,
Mhm.
at, and so that was my second kind of, entry back into talking to students and engaging with students,
Mhm.
because this was their first, class that they would experience taking care of the mannequins, cleaning the patient, giving medications,
Mhm. All
nebulizers,
those clinical stuff that we
abdominal
don't
dressing
miss.
changes,
Yes.
IM injections, just helping them to experience the basics, but, having a warm presence that would not be, the mean lady,
Mhm.
so that was something I enjoyed doing. That is what allowed me to get to the educator role in the hospital,
Mhm.
because I needed experience in order to become the hospital educator.
Mhm.
So the title nurse educator eventually, merged into nursing professional development specialist. So I've been doing that for the past 11 years
Mhm.
of the 21. So the role of the nursing professional development specialist is staff development, right?
Okay.
So in academia, as a professor, it's a slightly different track. But in the hospital setting, the staff development world, we're helping with orientation and onboarding. We're helping with program planning. We're helping with annual education and as well as professional development support for the staff. So
Mm.
any new, equipment product, any new patient population education rollout, that's what we're involved in. And it's an interdisciplinary collaboration with other, groups and disciplines to help them, make our nurses, help them with their competence, help them with their, care that they need to provide for the patient. So
Mm.
that's the involvement that I do in the hospital. So that's
Okay.
my 9 to 5.
Okay. I mean, I will say, just to like kind of back it up a little bit,
Mhm.
um, I could tell you do have a very warm presence.
Oh, thank you.
So I think that that is super important. I will say one of my experiences that I remember in school, that made me want to go into education. Not that I'm in education right now, but made me want to go into it was because I had like one of my clinical instructors was terrible. She just was not good at teaching. She was not that she was mean, but she just for example, I am a firm believer if we're nursing students, just like if you are teaching children, in any setting to me, it's especially if it's new to the group, that it's better to do it in the group as opposed to more of a one-on-one session. So
Mm,
what she would do is she would separate us. We would come into the hospital at 7 o'clock, and we everybody's up from the night before from doing all these like looking up the patient and all their like medical diagnosis, defining it, all these all the things that come with clinicals at nursing school, instead of us like learning together about like quintuplets where
right,
everybody has the same thing,
right.
essentially. She would separate us, so she would do like a one-on-one kind of thing, and that was her thing all the time. And so it just confused me because I'm like, how are we learning? There's stuff I'm missing because I could learn something like someone could be an AFib, and yes, I can essentially look up to see what AFib is, but it's different when you, as someone who's already in the field, can say like, okay, this is how you maybe you can recognize this. Someone might say something, and you're like, oh no, 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 you know what? That's not the right way. Or someone might say something and like, you know what? That's a great tip. You guys should definitely take heed to that. And I just felt like it was not a conducive learning environment. Um, and then unfortunately, we had a situation where one of the students ended up leaving at the end of the semester. I mean, I'm sure there were other things going on, but I just felt like that was also like the icing on the cake. Like she just was just like, nursing is just not for
Not for
me. And it,
her.
it just didn't help. So I just always was just like, you know what? I wish I could always have like a professor or a clinical instructor that makes it easier or makes me want to actually learn. And, I think that's half the battle. And that doesn't only apply to nursing. I think that applies to anything. You could apply to chemistry class. If your
Right.
professor sucks, then chances are you're not going to fare well. So I love that you actually do have a warm presence and that you seem so passionate about
Wanting to help
onboarding,
people.
about like, caring how people learn and
Mhm.
to get acclimated into the profession.
You raised a great point because adjunct instructors, one, they may have different formats of how they instruct. There's
Hmm.
going to be that one that's going to find all those opportunities for you. There's going
Hmm.
to be that one that's going to be giving you extra tips and allowing you to do things that probably they shouldn't be allowing people to
Yes,
do.
yes.
But there's also who's really observing them,
Hmm.
right?
Yeah.
So most of the time, it should look like there's some evaluation
Hmm.
summary that happens in each semester where people
Hmm.
can give feedback. So I don't know if the students are able to give feedback and if the schools are in fact looking at the feedback
I mean,
because that would
generally,
be
that
important.
I think I'm pretty sure that did happen, if I remember correctly. Like we did have to do some sort of evaluation. I don't know if the school is looking at it necessarily. I'm sure the school that I went to, I'm sure if people complained, like it would raise an issue. But yeah, I do, yes. People do
I'm
have different
hoping.
styles of teaching, and which, in general, I feel like I am open to that. It's just her particular style was just not
No, I
not good.
agree.
Yeah.
I agree. I would have liked to see stuff too. It's like, hey, we've got this patient with this condition. Let's all see as so and so helps with the dressing change. I
Right.
think that would have been important. A
Right.
group, it's helpful for groups to see what's going on because you only have so many weeks in clinical.
Mhm.
So, some schools it depends. It very depends on the school, but like what was the evaluation? Did they pay attention to said evaluation?
Mhm.
Did they care about making changes? I mean, students are bringing the money in,
Right.
so they really need to be listening to the students.
Right.
But yeah, the instructors they vary, and that could be a great experience or not. There's some nursing students across the states who will say, we weren't really able to touch the patient, or we weren't able to document, or
Mhm.
there's differences, and that could make them not feel ready and successful for starting their career.
Mhm.
So, yeah.
Did you ever go through anything like that yourself?
In terms of difficulty with an instructor,
Mhm.
yes, my professor was my instructor in the clinical site, and it was a nightmare. She, for some reason, she didn't really like me.
Mhm.
She screamed at me in the nurses station
Were you the
and
only one, like,
clinicals.
like, did you feel like you were
I was
singled
the
out?
only one
Okay.
because there were others that she seemed to love and, dote on.
Mhm.
But for me, she screamed at me. It was, you know, "What's taking her so long?" "Oh, it's Jasmine,"
Mhm.
and screaming at the nursing station. So
Oh,
I'm
wow.
embarrassed.
Wow.
My issues in clinical when I was in school, I could barely get the bubbles out of the insulin syringe when I was, withdrawing the insulin. It was a problem every week. I don't know why, but it was a problem. She was
Mhm.
annoyed with that, and she also she just was not very nice to me.
Mhm.
And it got to a point where one instance, I was on a unit. It was a unit that had patients who have a condition called MRSA, where you're supposed to be gowned up, you're supposed to have gloves on, mask, and it's contact precautions in place so that you don't, transfer any type of bacteria or viruses or things like that to other patients, but also you keep yourself safe with your PPE.
Mhm.
And we were changing the patient together, and we were adjusting the diaper or chuck, and it was one of the two. And as we were maneuvering the patient, it actually ripped. So I vocalized that it ripped, and this instructor, to shut me up, literally took her finger, her gloved hand, and touched my nose to shut me up. And that was just
First of all, that's disgusting.
disgusting,
And
inappropriate,
yes,
and a
egregious.
violation of
Yeah.
my safety and PPE.
Right.
I'm not You're not supposed to be touching my face. I mean, like, we all
Why
may
are
have
you even touching
a
me?
little MRSA on our skin or things like that, but,
Right.
like, that is
That's inappropriate.
inappropriate, and
Yeah.
I never told anybody about it. There
You
was this
never said anything
whole
to the
I
school?
never said anything to the school because there's a power dynamic of,
Yeah.
if I report this behavior, if I report how this person is treating me, I may fail my class.
Mhm.
And ultimately, I did end up failing my class,
Oh, wow.
but it had nothing to do with that day, but it has something to do with another day.
Oh, wow.
Yeah.
Thanks for listening to another episode of The Nurse Aspect, where we assess and evaluate. Keep it locked in next week for part 2.